Okay, everyone, I would like to welcome you to our session on residential, acute and community care settings. So firstly, welcome to our speakers, Nisha Joy, Dr. Julie Christie and Daragh Rodgers. My name is Sinead Brennan. I'm CEO of Engaging Dementia. I'm delighted to welcome you here to this session. We have sessions going on all day in this room, and we have another virtual room. So feel free to make comments. We have a Q&A there, so anybody who is with us, do feel free to make a comment, and speakers feel free to either respond to them during your presentation, or we'll keep the questions to a brief panel discussion at the end. We're also on Twitter. So for those of you who use Twitter, feel free to tweet. We're at Engaging DemIRL, and we have a hashtag DementiaConf20. Okay, so I will now introduce our first speaker, who is Daragh Rodger, an advanced nurse practitioner in care of the older adult community in St. Mary's Hospital in Phoenix Park. So, Daragh.
Okay, so this morning I'm going to talk about our journey in St. Mary's in the Phoenix Park, and just, how we got through it, had the impact it has had on not just the staff, but the residents, the families, the residents' families, and also our staff's families also. So it's just going to give a picture of what we have been through this year to date. So just for a little bit of background, St. Mary's is a care of the older adult facility based in the Phoenix Park in Dublin. We have a large campus, and it's made up of a hospital and a community nursing unit. So within our hospital, we have 48 beds, stroke rehabilitation, general rehabilitation, and a community response unit. And the community response unit, older people are admitted directly from home or after attending the day hospital, where they are deemed to require a short admission for either further assessment or management of an issue at that particular time. We also have a day hospital offering comprehensive geriatric assessment and ongoing medical reviews for our older adult population in Dublin North. And we have a healthy aging clinic which offers bone health education, osteoporosis screening, and it's a nurse-led service. Also on our campus, we have the Phoenix Park Community Nursing Unit, which is made up of 150 beds with 6 units with 25 beds in each unit. And we have one dementia-focused unit. And just to say that the majority of our units would have older adults with cognitive impairment or diagnosis of dementia within them. So in relation to COVID-19, I think it hit everybody by storm. One of my colleagues referred to it as we were waiting for a tidal wave, and what we got was a tsunami. And I think we can visualize what that looks like. So within Europe, if we know that the COVID-19 started in Wuhan in China in late 2019. By January, it had come across into Europe, and in the 27th of January, and recognising this, the World Health Organization European region set up the COVID-19 surveillance was implemented. And at the same time, on that date in Ireland, the National Public Health Expert team was created in Ireland. So again, recognising and starting to plan for what was coming. By the 21st of February, there was 9 European countries reported cases of 47 cases across the 9 countries. So within Ireland, then, if we move on to Ireland, The 29th of February, Ireland had its first confirmed case, and I think we were all tuned into that. Somebody arrived back from travel, went up to Belfast, and the case, that was the first case which was diagnosed or confirmed. By the 11th of March, Ireland confirmed its first fatality due to COVID-19. I think things started to get really real for everybody. By the 27th of March, there was 2,121 cases across the island of Ireland, and by that time there had been 22 fatalities. The numbers had jumped, and we can see the rapidity of this. By the 5th of April, 5,993 cases in Ireland and 204 fatalities. And by the 5th of April, also on that day, there was a report of 86 clusters in Irish nursing homes. And we're all aware of that. And some of us have gone through that, and others are, going through it at the moment. So what happened in St. Mary's campus? So we, in February, looking at all these news, what was coming along, we started our preparation on the 28th of February. And this commenced with pandemic preparation meetings with representation from all departments within the campus. And these were held twice weekly. And with guidance from our CNSP, Infection Prevention and Control. And these meetings examined and actioned IPC matters. And there to the right, you'll see some of the measures that we were planning for. So infection prevention and control around staff hygiene, education, staff bare below the elbow, educating service users and their families on hand hygiene and social distancing, supplying hand hygiene leaflets, posters and signage around the campus, just to bring everybody's attention aware to what was, potentially going to come down the line. We had posters and signage around the campus, procurement of PPE and IPC, and I don't think we really understood how much IPC or PPE we would have required at that time. But we did start looking for it and getting it in onto the site just in case. We did have access to and throughout the campuses, identifying isolation areas. And we also had a protocol for dealing with suspected cases of COVID. So we thought we had everything in place. On the 6th of March, following guidance from Nursing Home Ireland, we closed our campus to visitors. And there was a lot of disharmony about that from residents, I think from the staff, in some areas because on compassionate grounds and things like that. So from the advice of NIFET, we reduced it to restricted visiting. So we only had one visitor a week at that point. By the 13th of March, and of course the 12th of March, when the school closed down and we more or less went into lockdown at that stage, our day hospital closed. All volunteers, students and external staff that would access our site, all that activity was restricted and in some instances stopped. By the 18th of March, our campus was closed to all visitors except for end-of-life care. Between the 18th to the 20th of March, we had lots of challenges trying to get swab kits and timely results for those that we suspected may have been presenting with COVID-19. And we had our first confirmed case of COVID-19 in our nursing unit on the 28th of March. By the 30th of March, our first confirmed case of COVID-19 was in St. Mary's Hospital. And at that point, Public Health confirmed an outbreak. And just to say that we were in touch with Public Health every single day, our consultant geriatrician, our hospital manager, we had a direct link with them every single day for advice and guidance. And by the 2nd of April, we had our first fatality in PPCNU from COVID-19. And that was a huge blow to all the staff. And that was the first case that we had. I think it was a sign to everyone, oh my goodness, this is here. As I said, the 1st of April, we had our first fatality. By the 8th of April, we had 8 further residents detected with COVID-19. And we also had our staff isolating. So just to remember, when we had, once we had an outbreak, all staff on the unit where the resident was, who were in touch with the resident with 72 hours prior to that, all had to go off social staff self-isolating. So we did have a reduction in staff from that point. By the 12th of April, we had 47 residents detected, and we had 5 further fatalities. Our staff from the community, clinical case managers, myself as an advanced nurse practitioner, we were redeployed into the hospital to support our staff throughout this. Also, our clinical liaison nurse, our bed manager, we also had our tissue viability nurse, they were all redeployed onto the units to help and support as due to our staff shortages. By the 22nd of April, we really had a problem around staffing. So there was redeployment of staff from all areas within the hospital, our health and social care workers, our OTs, our physios, social workers, speech and language, and dietetics. And from helping with personal care to supporting during meal times, communication with families, that all was thankfully, it was as a result of that redeployment. By the 23rd of April, we were able to get COVID testing on site. So all patients and residents and staff were offered tests for COVID-19. And we did have a significant number of positives. Our last COVID-19 case was detected in the nursing unit on the 4th of June. So by that 4th of June, the outcome of COVID-19 in relation to numbers in our in St. Mary's was 103 staff had been infected, 8 of patients from our St. Mary's hospital side, and 79 residents for the PPC&U. And we lost 24 of our residents, actually 22 residents and 2 patients from COVID-19. By the 7th of July, the closure of COVID-19 outbreak in St. Mary's campus was declared by Public Health. So that is an awful lot to come to terms with and try and deal with. How has that affected our staff and our families? Well, as the slide, the heading of the slide is firefighting, because that's exactly what we were doing. We had reduced staffing due to sickness and isolating. There was anger and frustration around PPE guidance. Oops, sorry, something's happened there. Excuse me. I don't know what's... Have I lost you there?
We have it back there.
There, sorry.
Perfect.
We had anger and frustration around PPE guidance because that was changing on a daily basis, and that information was coming from Public Health. And also because of what our staff were seeing in other, like they'd friends working in the acute sector, they were seeing different guidelines there in the acute sector compared to what was being advised for our nursing homes. We had crisis management. We were doing the best for the resident under very, very stressful situations. And that was like on a daily basis. A lot of the time we didn't have staff who knew our residents, and of course it was residents with dementia. This was very, very hard because they were frightened, and also because they've seen staff in PPE and also voices that they weren't aware of. This caused a lot of stress for everybody. There was information overload and continually changing, sometimes on an hour-to-hour basis, and that was the hardest part. We had staff going out to support the unit to advise them on the latest guidelines from Public Health, and it might have been 2 or 3 hours after we had previously been around, and they were like, would you make your mind up, you know, why is it changing? And this was very difficult. We had bereaved staff as well, because remember, some of our residents would have been there for a long time, and even those who were only there for a short time, they were like extended family, and they were devastated. And the way things happened as well, because families couldn't visit, the usual end-of-life care wasn't able to happen. We then, of course, the redeployment of staff to support the PPC&U, and that was a huge help. We had increased anxiety among all staff due to fear of the unknown. We were not expecting what happened to happen, and it was you know, a terrible time. And there was fear for ourselves, for our colleagues, and for our residents. it was just ongoing. It didn't seem to be any let up. One day seemed to be worse than the next. So this whole experience has been very isolating, traumatic, and sometimes relentless for our staff. And when I was preparing this presentation, I did consult with the staff, and our practice development Fiona, coordinator Fiona, would have sent out asking people to share their thoughts and feelings on what we had been through. So a lot of this is coming directly from the staff on the front line. So what is the impact of COVID-19? So we looked at it from the staff, the residents and the family perspectives. So we have new ways of working because of it. The residents have new ways of living. Our families and friends have new ways of working and living, and also around the whole visiting, and everything just changed for everybody. The staff had increased workload because they had reduced staff numbers, and they had staff, new staff coming in who they were trying to familiarise with the unit at the same time, knowing that they hadn't got the time to do that correctly. There was decreased activity for the residents, decreased visiting and interaction for families and friends. The isolation, I think we all know the isolation right across the board for everybody, the impact of that. The wearing of PPE for 12-hour shifts for our staff, but more importantly, the lack of understanding and fear of PPE by our residents, and especially those who with dementia and with cognitive impairment. And also the concerns about PPE for our families and friends, because, you know, it was out there in the media and they were wondering what is going on up there because they couldn't come in and see for themselves. There was also, we had skill mix challenges. Again, we got whatever staff we could get. So there was challenges there. There was unfamiliar carers, led to disruption to familiar routine. And then for the families at home, there was concern over regarding care, were their families getting the right care, because they were just hearing there's all these terrible things going on up in St. Mary's, and as you were aware, it was very much in the media initially. Fear and anxiety right across the board, communication challenges for staff dealing with families, communication challenges for our residents who would have been familiar with our staff, but now new staff was in and didn't know how to communicate with them because they weren't familiar with them. And also for family and friends worrying about their loved ones in the hospital, how are they managing because of dementia. There was the physical impact, fatigue, exhaustion, burnout for our staff. There was reduced activity for our residents. And then for our families and friends, they're witnessing the physical impact on the loved ones. Staff had reduced lack of meal breaks. Our residents had altered meal times and locations of where they could eat because we couldn't bring them to the dining room. There was increased concern regarding altered meal times of their loved ones. Are they getting their things that they do like? Are they eating enough? You know, there was great concern there. In general, everyone was very overwhelmed, all staff across the site, and it was very, very visible on a day-to-day basis. For our residents, they were very unsettled, and our families and friends, they were very anxious and fearful of what was going on. Across the board, there was evidence of anger and frustration of how this has happened and why did it happen to us, and you know, this is really happening here. There was, for the staff, there was fear for safety of their own family and for the residents. Oh, they were going home to their families after looking after people with COVID-19, and even though they're following all of the guidelines, there was fear of passing it on. And for the residents, there was that fear for personal safety of their own family and friends, and also for the staff who they had become family to during their time here in St. Mary's. There was also fear for the residents, or for the family and friends. There was fear for their own safety and their loved ones. So you can see that there was a huge impact on everybody. So some of the challenges that we faced on a daily basis. With public health, there was frequent changes in guidance due to ever-evolving evidence. And that's no slant on public health. They were learning from the start. This was new to everybody. So the guidance that was coming through was ever-changing because of the new evidence that was coming through from China or from Europe, or all coming from the World Health Organization. The guidance on PPE for acute versus residential was very different as well. And as I said earlier, some of our staff seen their friends working in hospital situations who were wearing the PPE differently to and had more access to it than they had in the nursing home setting. The other big issue was we had a lot of our residents who were asymptomatic, and also for their staffs. They had confirmed COVID-19 on routine testing. They didn't have any symptoms whatsoever. And this applied to staff, residents and patients. So that was very hard. We also had people presenting with atypical presentations. And remember in the beginning, we were waiting for the shortness of breath, the respiratory symptoms, the high fevers. In older people that didn't present. So when we had people with GI symptoms, with loss of appetite, fatigue, no fever, no respiratory symptoms, afterwards we realized that, you know, these are atypical presentations in older people. And we know now that this has also been added in from the evidence that letting people know, don't be particularly waiting for the fevers and the respiratory issues. There was also lack of understanding of the true reality of the situation. And that was with everybody. Like we didn't know what was going to happen. We didn't know how big this was going to be for us or for anybody. And I suppose maybe we were naive, and when we did see it happening in other countries, and we just didn't think it had happened to us. The other issue that our staff had a huge challenge around was the nursing unit is the resident's home, and around cohorting, we had to respect their rights and asking them to, you know, to move them out. We were making them safer, but at the same time, this is their home. So having them communications with residents who have dementia without their families being there to support them was very, very challenging. And again, it was very traumatic for not just for the residents, but also for our staff. Communication with families was also very challenging, with suboptimal due to reduced staffing levels, visitor restrictions, and our priority was to patient care. We were lucky that we had our occupational therapy colleagues. They set up as ward clerks on each of our units, because our staff, we would get calls saying nobody's answering the phone. We didn't have the staff to answer the phone. So in the mornings we had, or actually in the peak of it, we had our OT staff there as communicators with our families, at ward clerk, I should say. And then our social workers would do online calls, video calls, and support our residents with those calls with their families. We also had isolation challenges with residents due to lack of understanding. We had some residents who liked to walk around during the day, and we had to support them and be trying to keep as normal as possible, but for them to realise that the usual routes they took, they cannot take now due to the virus and due to cohorting. So we did have companion carers with some of our residents just to support them through this very difficult time. Another big challenge for us was the daily media reporting, sometimes inaccurate, causing hurt and stress to all. And I think that was really hard, because we were doing a really, really good job, as we thought, and then to get hit by the media. And, you know, I know it's the media, but it still hurts our staff greatly. The other thing was the high level of sickness among staff. And also around new staff requiring high level support. And again, it's the challenge was not being able to give that because our priority was giving the care to the residents. So I suppose some of the words that came out in feedback from the residents, from the staff and from families was about the staff camaraderie, pulling together, helping each other out, staff flexibility. They went over and beyond to support everybody, the redeployment to new roles. This was all great support for everybody. Natural leadership evolved. We've seen this with our healthcare assistants, and I heard in one of the early presentations about the value of healthcare assistants. Well, they really stepped up to the mark, and sometimes they were the only familiar person on the unit, and they knew everyone in that unit, and they supported the staff nurses and the other staff who were redeployed in to support that particular unit. And, you know, that was a great thing to see. And again, the value of them. Everyone went over and above. The support from families and friends and residents was great. Our staff numbers were down, Prizes from local businesses lift spirits. They felt valued when they, a knock on the newspaper and then something nice from a local business, whether it be like care packages or and then communication just showed the staff commitment as well. Sorry about that. So what do we do now? We're preparing to live with COVID-19 because it isn't going away. I mean, as we know, we're in lockdown again. We've had planning and recovery meetings since we were declared out of outbreak. We've had enhanced measures to support communication and visiting with our staff. So we've been really working hard on all of that. There's been psychological support for our staff, the residents, patients, families and friends. And just to say, throughout the outbreak, we did have 2 psychologists on site offering support to staff at any point of the day. If they were having a particularly bad day, that there was somebody there for them to go and talk to. We are developing new ways of working with technology, with online meetings, communication and telehealth. And we're also reconfiguring and enhancing our existing facilities, because the one thing we didn't have was a lot of isolation rooms. So that's all in progress at the moment. And I suppose after all that, we have to reflect, we have to rest, and we have to recuperate. And these are words that came back from our staff. They wanted closure, and they needed time to heal. They were just glad they survived. Need to be mindful of other people's, how they got through it and how they have survived it. We're learning from it. We've got better understanding of what happened. So they're kind of some of the words that just came through from staff, and I think it's very important to be mindful of that. So that's what I want to share with you today. I'm going to play a short piece. One of our staff who was redeployed, Shirley Long, she was redeployed from a case manager to a site manager. Anna would have been working directly on the front line with our staff and families and residents at that time. So she's going to, I'm just going to have a little piece to play now. If I think Sinead is going to play it for me.
The last line. Throughout my nursing career, I have always worked in older persons' care, and I've seen the great lengths people have gone through to care for their loved ones at home. I know from experience that this unique bond doesn't dissipate over time or when an older person is admitted to a residential care facility. It is precious and should be treated as such at all times. One busy morning during my redeployment, I was doing the usual ward checks to see if the staff needed anything. I was coming to the end of my rounds and completing the final check of the morning when the nurse in charge remarked that one resident was sick and they had given him breakthrough medication. She stated that they had called the doctor to review him and she was on the way. I went to assess this gentleman just to get a clearer picture of his condition. He had deteriorated and was now entering a different phase of care, the end of life phase. His room was filled with things from home, framed photos of his family and hand-drawn pictures from his great-grandchildren. I asked the nurse had his family been informed. She said that she was just about to ring them. I called my colleague, a social worker, who had agreed to facilitate family contact and visits during this time. I stated that this gentleman's condition had changed and a family visit needed to be arranged. She said she would get back to me when she made contact with his family. After this phone call, the doctor arrived on the ward to review the resident. His condition had weakened. The social worker got back to me and said that his family would be in as soon as possible to see him. Due to his wife's age, she was deemed a high risk of contracting the virus, so we had to improvise. We brought this gentleman's bed close to the window so his family could see and talk to him and let him know that they were there. All contact and communication was through a pane of glass, a 50-year marriage culminating to this point. When you see the images on the television of relatives visiting their loved ones during this time, it definitely has an impact. But when you are actually in the room, dressed in full PPE, your perspective is very different. You feel a huge sense of responsibility and you want to make the situation better for all involved. But what you really wish for is that just this one time, the infection control restrictions could be lifted so that this family can say a proper goodbye. When I looked back on the experience, I wondered why it had such an impact on me. I have gone over it again and again, and I realise now that it wasn't that we had to improvise because of the current situation. It was because of one thing that I hadn't accounted for. It was because the normal things that we do as a practitioner in situations like this was impeded, curtailed by panes of glass, a face mask and protective equipment. The simple element of communication was obstructed. Communication is a fundamental component of nursing practice and essential to end-of-life care. It enables residents and their family to understand what is happening and how to adjust to their new situation. It allows us as practitioners to connect with the person that we are caring for and their families. If not carried out effectively, it can have detrimental effects on practice, especially at very sensitive times. And although verbal communication could be maintained at this event with great difficulty, non-verbal communication was a huge issue. I never realised how much I rely on it in practice, how much you say without saying anything at all. Non-verbal communication revolves around facial expressions, touch, and standing in close proximity to someone so that they know that you are actively listening to them. It is crucial in maintaining the humanity and compassion of nursing care, and an extremely powerful tool in showing empathy for an individual, especially during end of life. In the media, we are often referred to as frontline workers. However, I believe we are better described as last line workers, as we ensure that our residents and their families receive the highest quality of care in very difficult circumstances. We insist that their values and wishes are respected right until the end, and we hold their hands when others cannot. We are the last line, and we are privileged to hold this position. Thank you to Shirley Long, Clinical Case Manager, for sharing this reflection.
Thank you very much, and I'm very sorry it went over my time. Sorry to the other girls.
Thank you so much, Daragh. I'd like to just say a very heartfelt thank you for sharing such a difficult story, and sharing it also on behalf of staff and residents, and for taking the time to go through all of that and to share your story with us. And for Shirley's extraordinary story there. I don't know how other people feel, but very, very emotional, that the human impact of COVID on the people that you're caring for and all of us as a whole. So thank you so much for that. I'd like to introduce Dr. Julie Christie now. And Dr. Christie is Service Manager and International Visiting Research Fellow at the University of Edinburgh and Adjunct Lecturer at the University of New South Wales. So I'd like to introduce Julie to you now. Thank you, Daragh.
Hi everyone, I'm just getting organised with my presentation. So yeah, I mean, that was very emotional listening to that, Daragh, so I hope you're happy that you've got me very emotional before I get ready to do this presentation. But we so need to hear these stories, and every day I hear stories that just make me feel so blessed to work where we do and to be able to be with people in these intimate moments and to have carers that care so much. So thank you for that. So my presentation is about the Dementia Support UK service, which is a service in England that is purely there to support the care staff that you were just referring to. So we're not a clinical service, but we support care teams as they care for people with dementia. So for people who haven't heard of HammondCare before, we are an Australian charity and we have a UK-based team. So for a number of years now, we've been working in the UK on research, evaluation, consultancy, teaching. But in Australia, we deliver direct care services. So care services at home, We have an International Dementia Centre. We deliver residential care in small domestic home-like settings. And we also deliver the Australian Government's Dementia Support Australia service, which gives free advice to anyone who's caring for a person with dementia at home, in a hospital or in a care home setting, where the person is experiencing behaviours and or psychological symptoms of dementia. This service is an adaptation of that. So in England, the UK government put out a call during the pandemic for business-led innovations to respond to the problems of COVID. So we saw an opportunity for a small pilot akin to Dementia Support Australia that could support care staff in anticipation of the problems that people were going to be experiencing, and that Daragh described so perfectly in the last presentation. So in England, there are 457,000 care home beds, and they are delivered by approximately 11,000 care homes. I'm sure over the last 2 days you've heard lots about the stats and the impact, but the kind of most striking stat, and we must never forget that these numbers are individuals, you know, with families, and really the human cost of what has happened here. But there have been 30,500 excess deaths in care homes during this pandemic. And since March, visitor restrictions have been in place. So for some people in England who even haven't been able to have window visits, some people have had no visitors. So it really is quite a striking state of affairs, and one we could never imagined a year ago. We have just in the past 24 hours contributed to a letter that the National Care Forum in England has put out to our MPs, really calling for visiting and essential visitor status to be set up as a matter of urgency. England is just about to go into a second national lockdown on Thursday, but there are lots of areas of England have had local restrictions. So we really need to do something about this if we are to support care staff and support people with dementia during this time. According to a study by Deeney and Dunn, England had one of the highest excess death tolls in Europe during the pandemic. Is really incredible. So this work is so important. What we know, there have been a flurry of research papers already, and we're very grateful to everyone who's tried to understand what is happening so that we can be more prepared as we move forward. But already we know that a lack of PPE, a lack of testing for care homes, and test results not being available in a speedy manner, infection control practicalities. So as Daragh said earlier, you know, care homes are people's homes, they're not hospitals. They're all designed very differently. Staff, you know, have different levels of knowledge and skill in relation to infection control and what's expected of them. But we also know that staff have moved between care homes and that there have been discharges from hospital to care home. So there are a lot of contributory factors that have led to the experience that care home staff and people with dementia and families have undergone during this period. So whilst the country still debates what more could have been done, we really need to move to doing things differently and seeing that staff are on the verge of burnout. Staff need to be supported if we are to care well for the people that we do provide support to at this moment in time. And the headlines, you know, over this period really tell the story. There's been a risk of reduced quality of care, a higher workload for staff, interruption to the taken for granted support structures, community care home teams, clinical support, GP support, and importantly, the support that family carers provide, and the risk of emotional ill-being through that family contact being lost, that human touch, the reminders, the care tasks that families provide as part of the care home communities to support people, it's all been lost. So we know it's resulted in organisational and individual stress. And we also know that some care homes won't survive this period in England, so that it is a real risk that care homes will go out of business. There's real anxiety about what the future holds. The need for palliative care work has increased. Much loved residents have died. At the same time, there are also care homes with excess bed vacancies, and staff have felt isolated, and that the equipment, the loss of human touch and interaction between your colleagues and the people you care for has really taken a personal toll. Importantly, there are also real gender and ethnic dimensions, because it's normally women that dominate the long-term care workforce, and it's in the UK very heavily dependent on migrant workers. So we have a moral responsibility to care for our care staff, and I don't think we've been doing a very good job of it so far. And then we know that the impact on people living with dementia has been devastating in some circumstances. So there's an increased, the ONS data has told us there's been an increased use of antipsychotics over this period in England, which is significant because we know that the death rate has went up at the same time. And Robert Howard has recently produced a Lancet article on that, which you might be interested in viewing. There's been increased agitation and anxiety. Routines have been interrupted. As a result, there's a real risk that pain can go unrecognised. There's unfamiliar staff and locations. There's an increased risk of delirium. In England, there's also been a quick admission process to care homes. So where older people living with dementia have been in real crisis, care home admissions have sometimes been facilitated more quickly because there's been interruptions to domiciliary care. As a result, staff sometimes haven't had the same opportunities they would have to get to know the person before they come, and the person has also been admitted in crisis, or the care home is not, you know, the stable place that it was because of interruptions to staff and people moving around the facility for infection control. What we've also found, however, is that the quieter environments with less visitors have actually suited some people with dementia, but for others there's a real risk of apathy. And the isolation from families and the lack of familiarity with routine and the close contact with staff has really been a problem. So it's within that environment that Dementia Support UK was born, because we need to support care staff. I know I've said this several times, but that was really the point of emphasis. So just to give you an idea of how the service works, we are a consultancy service. You make referrals either by phone or online, and you can refer online 24/7. And what we found was that in one circumstance, a care home had had a gentleman called Michael, who had been admitted very quickly and he'd been very unsettled. So for 3 months, he'd been very agitated, especially at night. He'd been up overnight, and the care staff were really struggling to find strategies to reduce his distress during this period. So at the handover, the night shift reported to the day shift that Michael had had another night where he was very unsettled, and the staff were then able at the handover to make a referral at 7:30 in the morning to relay that they needed support with this issue. And a Dementia Support UK consultant was able to contact the care home that same morning. In discussion, it was thought to be slightly more complex and something that could be resolved there and then on the phone. And so a consultation was arranged for 2 days later to develop an action plan So I'll return to Michael at the end and just let you know what happened there. So this is what the Dementia Support UK website looks like, and anyone can visit it. We have resources that you can download for free, so you don't have to be in England to access them if anybody would like to have a look and see what we have there. So you can refer online through the website. Between the 1st of June and the 28th of September, the website had a remarkable almost 4,500 website visitors. We had 113 referrals for a problem-solving video or phone consultation, and we've had over 1,000 resources downloaded, and all of this is free at this present time. Our resources include practical help sheets, carer support guides, ebooks, spotlights on research, and position papers. As well as care home staff, resources can be accessed by family carers and other health and social care teams. They've been very well received, and we've also had requests for specific topics. It's a really interactive forum, so people can also say they would like help with something, and we can then develop a tip sheet for them. And importantly, it's a relationship-based model. So one of the things that's very important to us is resilience and how we can promote the resilience of people with dementia. So what we've done during this time is take a model of resilience building in dementia and use those pillars to support staff. So we think that's highly unusual, that we're actually taking knowledge about what works for people with dementia and seeing if that same knowledge works for staff who support people with dementia. So when we connect with the care home, we find out what's going on for them, because everybody's situation is so different. So, you know, what's happening in your care home, you know, what's happening in your area, because all the lockdowns all had different arrangements. What support do you have access to? How are you feeling? And then work out what the best strategy is to problem solve, whether that's something quick there and then on the phone, or the member of staff would like to book a sit-down video or phone consultation. In doing that, we consider ourselves to be nationally consistent but locally responsive, and we really try hard to understand what would help that particular member of staff, that particular care home, and a particular person with dementia. And as a result, we problem solve together rather than thinking of ourselves as consultants coming in to impart knowledge. Healthcare assistants, the care team, they get to know people so well, they try lots of things, they're natural detectives and problem solvers, so we tap into a lot of that information as well, because when you're tired, you can forget that you're good at your job really, and your job really doesn't feel like your job at this moment in time. So it's sometimes good to have a mirror of someone reflecting back to you all the skills that you do have. And the other important part of this work is gaining an insight into what are the problems from the perspective of care staff that they struggle to find solutions to. So for every person with dementia who's been referred for a consultation, the person's had an average of 5 behaviours that the care member of staff has asked for help with. That's quite incredible. So that's 5 behaviours per person that someone would like help with. The most common behaviours are agitation and aggression, motor disturbance, anxiety, irritability, and nighttime behaviours. And you probably won't find it surprising that the behaviours with the greatest impact on the person with dementia are also the same behaviours that carers find most stressful. And we've also found that pain and delirium are major contributing factors. So they've had to be addressed in 65% of our referrals. Now, before I go on to talk about impact, it's also worth saying that we've also been doing an exercise looking at how many behaviours can be linked to the impact of visitor restrictions. So we will soon have data that links different behaviours and care staff stress, both explicitly and implicitly, to family visitors being unable to be with the person. So there'll be more on that later. In relation to impact, 85% of respondents have reported that behaviours have reduced. 73% of respondents reported that their stress as a carer has reduced. They also said that they would feel confident dealing with the same behaviour or issue should it arise again. And they would also feel confident using some of the same problem-solving strategies with another resident if they had some of the same issues, problems and/or behaviours. And importantly, for wider health and social care value, 73% of residents, according to respondents, would have been referred on to a more expensive health service, including a mental health team, a hospital, or there would have been a risk of the care home package breaking down. So they might have been looking for support in order to find a solution if they felt that the situation wasn't sustainable in the long term. So it's really important that we can support placements to continue, especially during a pandemic. And so importantly, returning to Michael, on discussion with the care team, the consultant learned that Michael had been a railway worker and he would have routinely worked night shifts, but he'd also been admitted in a crisis to the care home. So he'd had delirium in hospital. He had no family that the care home could speak to at the immediate admission point. And as a result, he didn't get to enjoy a settled period of choosing to move to the care home, getting to know the care staff, becoming familiar with his environment. And he appeared very angry when the staff were trying to engage with him. What we agreed when we met is that that was probably a very understandable reaction from Michael's perspective. He hadn't chosen what had happened. He hadn't accepted that he needed care, and he was very upset as to why he was there, and he really couldn't communicate it. The care team were worried that the care package was going to break down. He had been referred to a GP and he had been started on antipsychotic medication, but the staff reported that it really wasn't helping him to sleep. So the referral required a combination of attention to physical health, including pain. It came to light that Michael had a leg injury, so he needed pain relief, and the staff reported that quite quickly after receiving pain relief, his behaviour was more improved from their perspective. They then started to look at what his pattern of going to bed had been like at home, and it turned out that Michael used to have a big bowl of cornflakes. Other cereals are available. He used to have a big bowl of cornflakes at night with hot milk before he went to bed. So staff started to introduce that as well. So by working closely with Michael, the care team personalised his bedroom according to what they were able to find out about his home life and his work life. They provided environmental cues that bedtime was approaching, including the cereal, and they also ensured that he had his pain medication at the right time. So they continued to liaise with his GP, and as new things arise, there's a problem-solving approach where people get together again to revisit, do they need to change anything in their approach? But importantly, from Michael's perspective, the staff, and for our own, changes in behaviour were noted 48 hours after that consultation, where Michael enjoyed his first full night of sleep. So everyone involved was delighted, as were we. So just to finish, the coloured buttons that you see here are really what we've been able to identify as our USPs in the delivery of this service. So the things that we are able to do at this present time that there's been a gap in the market for, essentially. So staff have been able to report very quick impact of consultations. They have appreciated the real-time problem-solving, responsive nature of it, because it gives a sense that, you know, you're not alone, and, you know, you can have someone walk alongside you to help you solve what might be considered quite a trivial problem, you know, like a person with dementia isn't sleeping at night. That can be seen as, you know, quite mundane. Maybe people wouldn't regularly refer out for help with something like that. Especially in a pandemic, care home staff were really conscious how busy other agencies were, and really were being very careful only to refer, you know, things around aggression, agitation, what they considered to be the higher priority behaviours that they needed assistance with. Whereas a service like Dementia Support UK, you can get in touch with them about anything at all. We help with capacity building, so around staff training, staff knowledge, but we're also very accessible in terms of how you refer to us, but the types of things we can access for you. So we provide free design consultancy related to behaviours. We provide free bite-sized training and learning. So the solutions and the problem-solving action plans really take in an eco-bio-psychosocial approach to dementia, and we pull on lots of different resource strands in order to help you with whatever your problem is. It's sustainable, so it can be delivered during and post-pandemic. It's adaptable, no matter what circumstances you face. And we describe it as a technology bridge. So there is an app in development, and we see really an app being able to, for those people who want to just get the information they want and download information, they can do that. People that want to speak to someone can also do that. And care teams who are interested in the relationship-based problem-solving model can book time with a consultant, because staff have also told us in some cases they're really very busy and they would like to have the problem-solving approach, but they don't have time for it. So this approach is really a bridge where you can pick the strand of support that suits you and your care team. And so if you would like to know more about Dementia Support UK, moving forward, we think there are opportunities for a service like this to be available as a subscription model. So we've lots of plans afoot as to how we can support people better. We don't know what the future is going to hold, but we do know that we need care staff and that we need quality dementia care. So having a quicker, more responsive approach, real-time support is so interesting in terms of how services can evolve. The connections have never been more important than they are now. So with Dementia Support UK, we're using our connections and networks to hopefully build capacity within the care sector, no matter what comes our way. So if you would like to know more, then do please get in touch, and thank you.
Thank you so much, Julie, for that very interesting presentation, and so good to see how that service has responded and that those resources, so even if the service isn't available here through dementiasupportuk.org, there are a lot of free resources in that people here in Ireland can access immediately. So that's, yeah, that's really great. Thank you. Okay. So I will now introduce Nisha Joy. And Nisha is the person in charge at Carebright Community. And Nisha is going to look at the impact of social isolation on people living with dementia and supporting people at this really challenging time. So I'll hand over to Nisha now. Thank you.
Thank you, Sinead. As Sinead said, my name is Nisha Joy. I work as a person in charge for Carebright Community in Bruff. Carebright is a social economy business, and it's governed by a voluntary board. Carebright Community is Ireland's first purpose-built dementia village in Ireland. It's based on a Dutch model. It's called Rodger. It's in Holland. So our village consists of 3 bungalows with 6 bedrooms in each house. So just to give you an oversight about how we operate things. Each bungalow has a big sitting room, a dining area, a kitchen, a utility room, and a big entrance. Each bedroom has a double bed, a normal double bed, an ensuite toilet, and it opens to a private garden. So we need people to bring their own furnitures from their home and their garden furnitures, their plants, pots, anything and everything to make it home for them. It's a household model of care in which 6 people living with dementia work towards meeting the household chores. So this includes like a normal home. You get up in the morning, you look after your own needs, then you maintain your house. It's a 5.5 million project. We have 4 acres of land and beautifully maintained garden. We have boreen, we have raised beds, we grow vegetables and plants. As part of the model, we have a cafe which is open to the public. We also have a daycare, a social day club, which is focused to help for people living with dementia. It runs 4 days per week. We believe in independence. We believe in freedom. We spent years and years coming with the right model for assisting people with dementia to have a best quality of life. A normal day for someone who's living with us would look like getting up in the morning, getting dressed, helping yourself for the breakfast. They would go and collect a newspaper from the reception. They would go into the cafe, will order a cup of coffee or tea, and they'll read their newspaper, they'll meet their friends, and they'll go back to their own home. Then the focus would be getting the lunch or preparing the lunch ready. So that would include peeling the potatoes, putting the meat into the oven or into a slow cooker. Everybody is together working towards the lunch as you do in a normal home. People then would go to the daycare around 10, half 10. They would meet their friends, neighbors, and they would be part of the daycare. So this is like, if you're living at home, you get up in the morning, you get dressed, do whatever needs to be done in your own house, then you go to a daycare. So it's a socially engaged daycare, rather than it's not run by a nurse. It's run by a normal person, but it is supported by a nurse because it's in the same campus. I suppose our cafe was open, and we wanted our people living with us to come into the cafe, meet their friends, be normal, be connected, have yourself connected to the community because it's open to the public. You are free to come along and to be part of whatever happening in the cafe, in the daycare. Our local community, Bruff community, we are in the middle of the town, played a huge role. We have very committed team of volunteers who assist us in delivering activities. They help us in fundraising, anything and everything. We have huge support from our local community. I suppose in last year, 2019 summer, we organized a trip once in a week. We had a trip. We went to museums, we went to garden centers, we went to swimming pool once a week. We went into Woodlands Hotel to swim and had lunch. We came back by evening, and we went for movies. So I suppose our life was going out, doing things, be part of the community, and do whatever you have to do to stay connected with your community. And Carebright was very sure in the beginning, when we came up with this model of care, we wanted to be in the right middle of a community to hold up that community spirit. Our families played a huge role. We have an admission committee, so the committee makes a decision who can live with us. One of the criteria was the family members had to come and visit the person 3 times a week. It's just not to tick the box. It has to be a quality time spending with your own loved one and the rest of the housemates. Since COVID came, we had to move away from the social care model to a medical model. We had to stop everything that we had to do. COVID hit us hard than a normal nursing home because it was normal for us to go out and do things. It was quite abnormal for us to stop everything, that you had to stay in your own house. You can't go out. You cannot go and visit your neighbors. Each and every house was cocooning themselves, so that people were living in their own house. They weren't allowed to go and visit their neighbors. Due to pandemic, we had to ask some of the staffs had to stay at home due to their personal reasons, and we had to recruit a bunch of staff to replace them. All of the staff who joined during this time, they landed into a medical model of care, where the temperature was checked every hour, every day. Hand washing was more priority than spending time with somebody. We had to move away from being there to not to be there, and to stay away from everybody. I suppose our baking session was one of the beautiful, divine sessions that everybody looked forward to. We had 2 volunteers who were real bakers, enjoyed baking in our house. Everyone came together. There was loads of energy, loads of buzz, loads of gossips going around that time. People looked forward for baking. They put their hands into the dough. People were busy in peeling apples, putting the tarts into the oven, waiting for it to be ready. Some of our people joined just for the gossip and a cup of coffee and a free tart, and which was meaningful. We had family members joining us for the baking session because they felt it therapeutic. They felt it meaningful to be part of it, cleaning up after the baking. So they felt themselves good. They were doing a quality visit to not only to their mom or dad, to everybody in the house, because that was a very socially engaging time. Since COVID, we had to stop all our activities. We had to stop all our volunteers. We had to close our cafe. We had to close our daycare. And we had to say no to all our outdoor trips. We couldn't go to the shop anymore. We had to adopt a new way of living. Staff had to put themselves into a new way of working. Usually, if you want to borrow something from your neighbor, you would go into the house and get whatever you need, like sometime butter, sometime milk, whatever. But now you had to ring them and ask your neighbor to pass it through the fence. It was just a way of saying no to everything and to go into a different way of living. In the last pandemic, we had in the last lockdown, we had staff working 7 days on, 7 days off. So that staff were working 1 week completely for 12 hours, days and nights, then having 1 week off. We had 2 staff nurses, including myself, covering the 1 full week. So that's 14 shifts covered by 2 nurses. We did everything. It was hard. It was tiring. It was completely against everything what we wanted to do, but we had to do it, and we go through it. Social isolation played a huge impact on people living with dementia, because it was quite abnormal for us to say no to everything, where our doors are open all the time. We don't lock our house until 10:30 at night. We want people to go out, put on your jacket, go out for a walk the dog, walk our goats. That was normal, where we had to say, no, stay at home, we will stay at home. Everything was, don't do it now, don't do it. we had a lady went to isolation after her hospital admission. She felt abandoned. She felt heartbroken. She even started crying, and she said to us that, am I a nuisance to you guys? Is that the reason that I have to stay in my room? She rang her family and she said to them, look, they don't want me here. Nobody talks to me. Nobody brings me to the dining room anymore. So she had huge depression because of that. That was a very tough time, heartbreaking event for us, for herself, and for her family. We have people who have hearing impairment. The lady who has hearing impairment, she read our lips. So when you wear mask 24/7, there was a huge communication gap. And as part of it, there was loads of frustration. The visiting was closed. Because of visiting restriction, people lost weight. One of our ladies' daughter, she came every morning with freshly baked scones. So everyone sat together in the house. She helped herself and everybody. They all had a cup of coffee and a fresh scone in the morning, which was such a beautiful feeling of home, where we had to stop everything. We could not get anything from her home. She lost weight. She went into depression. There was huge impact. We have a lady lives with us. We have a gentleman living with us with Lewy body dementia. He's in his 60s. Going home, being part of the home, he thrived going for lunch with his family every Sunday, and he felt heartbroken not doing it. He always called himself king of the castle. He never wanted to help anybody in the kitchen, where when he went home for lunch with his family, came back in good humor after having a glass of Guinness. He wanted to help everybody. He wanted to be everybody's friend. His mood was so bright and happy, where everything is gone now. He can't. He thrived for that hug from his grandchildren, and we can't allow that to happen, and which is heartbreaking. We have a lady with semantic dementia who joined us recently. She's 52 years of age, and she was working in Department of Justice until March. I mean, I could easily put myself into her shoes, who was working up to March, who was driving to work and driving back home. She could not understand social distancing. She could not understand the risk involved because of COVID. In an ideal world, she could have easily come to our daycare, and she could have worked in our office, which she can't do. And she came to us. Usually, we would bring her into our office, and she would be part of the office staff, and she could work away and get paid every week like we do for others. But our home care admin staff interact with nearly 180 home care staff. There's a huge risk involved, so we could not bring her into our office and to be working from our office. So we do engage her. We do, I suppose, meet her needs by going for long walks, one-to-one. And she's quite settled now in the home, but she could do more if we didn't have COVID. And her life could have been in much better. We could have done so much productive things together. Before COVID, people used to come to our cafe, they collect their bread and milk, where now everything is cleaned and wiped down and delivered into their homes, which is abnormal for us. It's quite unusual for us. I suppose after last lockdown, we celebrated each and every day. We got our hair done, we got our nails done, and we had to start our own social activities back. As a manager, as a team leader, I had to think differently. How could I bring the social engagement back? So as thinking differently, I suppose I had to ask one of our staff who had huge interest in knitting to lead the knitting session, and she does a wonderful job. The staff who supported the volunteer for baking session is now leading the baking session. We have our maintenance man who is a musician delivering music. We have staff who is keen in fitness, are delivering exercise class, yoga class. We have a nurse who is a trained art therapist, is now delivering art session. So it's thinking differently rather than, I suppose, for us, we could easily move into a medical model of care. But if we do that, we are working against our ethos. We spent years and years to come up with this kind of project to give the best for people living with us. And we just can't forget all those. We can't let COVID take away all the good things that we did for our people living with us. I suppose for us to deliver the best quality of care, we have the right environment, we have the right staff. I could easily put myself into Dara's shoes and feel the pain that she went through. I could just imagine, I mean, each and every one of us live in fear, thinking that COVID will get into our home and will wipe down everything we did. And because we are very small, there is only 18 people living with us. That could easily happen. But I suppose if anything at all to learn from the pandemic, a household model of care will work better, as we can recreate a home for them. We only believe, we only hope that our policymakers, our government will look into innovative projects like a household model of care or a different model of care than a traditional big nursing home model. It would improve the quality of life for people living with dementia. That's all from me, and thank you so much. I feel privileged to be part of this platform, and thank you from everybody in Carebright.
Thank you so much, Nisha, for sharing your experience. And again, I suppose like Daragh sharing it so honestly and giving us an insight into, I suppose, the challenges and the impact on people living with dementia in particular, I think, and then how staff are responding to that within the current restrictions. I was struck by the impact that all of the speakers have described on, in terms of that experience of, the behaviors for someone living with dementia, and how it's the same behaviors for all of us, that what you described, anxiety, the impact of social isolation, irritability, depression, all of those kind of behaviors that I suppose has been so universal. And I know you've all spoken about that kind of universality. Is there anything in terms of, you were speaking about a new way of living and a new way of working. So looking ahead to the next 6 months, having been through the experience of the past 8 or 9 months, is there anything now that you are doing differently to try and overcome all of those, the initial challenges, particularly, I suppose, the impact on nonverbal communication that all of the infection control and PPE has brought?
From our side, we have a group of people just looking after 6 people. So it's the responsibility of each staff to take responsibility for their own home and for their 6 people. So if each person takes responsibility to protect their 6 people, I suppose that brings back the personal responsibility to our home. We don't have staff mingling from one house to the other, which we used to, which is again against our model, but we had to do it. And it's been working very, very well, I must say, it's good.
Okay, and are you, people wearing masks within that, or is it taking that pod?
Yes, no, we do wear masks 24/7.
Okay. Okay, and Daragh, what about yourself?
Yeah, I suppose a lot of things had to stop, as Nisha mentioned. Things had to change during this time, but we're very lucky to have a very good activities department run by Catherine Lawler and Miss A&M. And we have we did have residence committee meetings held with which they all used to come together, but now they're actually hosting them with the social worker on each of our 6 units and getting the feedback and from each of the residents themselves on what we can do differently or how to help them going forward. and what things they'd like to see or what they'd like to do, and as a result of what they've just come through. So it's listening to the residents and what they want, and I suppose working together to be able to deliver that.
Yeah, yeah. And Julie, any comment to your side, or do you feel that's been covered?
On our website, we've got a number of help sheets and tip sheets about the different aspects of adjusting to wearing PPE. So we have, a help sheet on kind of working closely with a person with dementia. We have one about, being prepared for room moves or additional social and or physical distancing, how to respond to behaviours and psychological symptoms of dementia, whilst also maintaining the distancing that's required. So we've got a number of sheets on different things that staff might continue to need help with, because the things that you do all the time, they don't go away. You just got to find a different way of responding. So some of our stuff's very practical, and others is about rethinking what you would normally do as part of great dementia practice and ways in which you can still achieve it, but just the differences that you might need to make. And as I say, I've really loved hearing, from Nisha and Daragh about the work that they've got going on. We should never forget how lucky we are to work with great colleagues at a time like this. So yeah, I feel very blessed to have been able to hear your stories and hear the really lovely everyday accounts of what people are trying to do to support colleagues or support residents. It's really remarkable.
Yeah, thank you so much. And there are comments coming in here through Q&A as well, just about that. Thanking you for sharing such a deeply moving experience. It's so helpful. People are commenting on how helpful it is to hear that and to learn from you, because sometimes difficult stories are not easy to share, and it's a huge impact. So thank you very much. I'm afraid we have to finish up now. All of our sessions are being recorded, so they will be available at a later date. And I'd like to thank all of our speakers, Dr. Julie Christie and Daragh, Rodger and Nisha Joy. Just before we finish here, I'll just share one more comment before we finish from someone who has said, the wonderfully brave and selfless work that's been carried out by people all across the service during this really challenging time, and that it needs to be acknowledged and recognised. And then those stories and narratives should determine how dementia care is planned in the coming generation. Sadly, it's taken a pandemic to expose the weaknesses in our health systems, but also the heroic and dedicated people in our services. So thank you, Breach, for that comment. I'm going to just launch a little poll before we finish here, and just for people to give us an idea of just their responses to the session. And feel free to continue to join the conversation on Twitter, #DementiaConf20. Our next session is starting here at 2 o'clock, and there's also going to be a session in the other room. At 2 o'clock, the Global Brain Health Institute, that's one of our partner organisations for the event, are hosting a mini symposium. So that's chaired by Professor Brian Lawler, and there'll be perspectives from all around the world from their graduate Atlantic Fellows. So thank you so much to the speakers again, and we'll be tuning in again at 2.
Thank you.
Thank you. Thanks.
Thank you.